Hello, everyone, and welcome to the March 2019 HHQI CardioLAN. We'd like to thank you for joining us today, whether you're participating in the live event or whether you're participating in the archive recording. We do appreciate your time. So today you have joined us on a very special day, as today is the annual event where we have the opportunity to hear from the Frontline. And we've listened to your feedback, and today we have only invited one agency. As you've told us in the past that having more than one agency leaves not enough time for Q&A and discussion, and that's what we want today to be about. So as our guest is sharing the story of how they've faced the daunting task of improving the quality of care of their cardiac patients, we hope that you'll take advantage of their experience and their willingness to share and bring forward any questions you may have. Now, as always, because of the structure of our annual Frontline presentation, no CEs are being offered today. Now, a few housekeeping items. Lines are muted. Feel free and please use either the chat feature or the Q&A feature, or if you are listening to the archived recording, or if you're just in a listen-only mode where you're not actually participating in the webinar today, please contact us at hhqi@qualityinsights.org with any comments, with any questions that you have that you would like to ask today's speaker. So a few updates that we like to share every time, just real briefly, as far as campaign announcements. We wanted to just let you know that the HHCDR, the January discharges, for those of you that are abstracting in the registry, you still have 3 weeks to enter that until it's closed on April 14th, so we want to thank you for that. Also, we wanted to just give you an update. Ischemic vascular disease use of aspirin, it continues at complete registry. Now remember, we don't call these national rates. These are just registry compliance rates of around 76%. That's decent for aspirin or other antithrombotics. We could do a little better in home health, but that's okay, we're getting there. Hypertension control, very pleased at a 79.8, almost 80% compliance on the hypertension control. That means the patients that are being discharged from your agencies with the medical diagnosis of hypertension are being discharged at about an 80% rate with a controlled blood pressure. Now remember, that controlled blood pressure, we're talking about less than 140 over 90. So kudos to you. The national rate outside of this is staying around the 60 to 70% mark. So we're very pleased with this. Home health is moving forward. Cardiac rehab referral, it is climbing, and currently we're at 31.7, almost 32%. That means 32% of the patients who should have a cardiac rehab referral are receiving it prior to discharge from the home health agency. Now, we expected that to be low because this is new for our setting. But remember, the cardiac rehab referral can be on the day of discharge to still meet this measure. So congratulations to those of you that are focusing on that. And statin therapy, we're pleased about this one too, hanging in there at around 70% compliance. Now, all of these have the room for improvement, of course, but you guys are doing excellent, so keep it up. And for those of you that are not participating in all of these, you may want to expand and go to another one, because this is something that we can do in home health to show what it is we're able to do. All right, let's move on to today's presenter. We're very pleased to have Angela Audette with us. Angela is an RN. She's a chronic care nurse navigator at HopeHealth visiting nurse. And in this role, she has become the cardiac disease educator for both staff and patients. Angela has recently led the HopeHealth visiting nurse team in achieving the Cardiac Milestone 5 and is working to expand the cardiac program for home health care patients. Angela is certified as a pulmonary disease educator and is also pursuing heart failure and nursing certification. Prior to her current role, she worked as an admission nurse in home care and an ICU nurse for 10 years. She holds a Bachelor of Science in Nursing from Rhode Island College. Please join me in welcoming Angela. Angela, the floor is yours.
Thank you, Cindy, and I'd just like to say welcome to everyone who could come today and listen to kind of my story. My name is Angela, and yes, I am the chronic care nurse navigator for HopeHealth visiting nurses. We are a home care agency out of Lincoln, Rhode Island. We serve patients in most of the Rhode Island state and into Massachusetts. Our agency is part of the HopeHealth family of services, which supports patients and their families through all stages of illness, providing hospice care, palliative care, skilled home care, and support for dementia and Alzheimer's patients and their caregivers. Our agency was actually first established in 1908 as the Anti-Tuberculosis Association out of Woonsocket. We are a nonprofit organization caring for patients from the inner city of Providence to rural areas north and south of the state. HopeHealth Visiting Nurses has grown. We've changed our name, but we continue to be a patient-centered agency with the goal to provide the best care possible for our patients in all aspects of their needs. So, what is Chronic Care Nurse Navigator, just besides a mouthful of words? The role was created about 2.5 years ago to help us keep chronically ill patients home and out of the hospital. Over time, I have done research regarding rehospitalizations in home care along with chronic care programs. I also examined how to best assess risk factors for rehospitalization, congestive heart failure, and other cardiac diseases. This was a completely new role, so it's been built from the ground up and it continues to develop and change. From patient and staff education and understanding to plans for high-risk chronic diseases and to the support we provide our patients, I look for what can we do better. The questions I ask more than anything else is what is missing and what more can we do? So this gives my role not just a clinical value, but also a quality component to it. Our patients cannot benefit from our services if we're not providing them everything possible, and there is an overwhelming amount of cardiac disease amongst our patients, which has a significant effect on their rehospitalization, and that was really where I needed to begin. So the first place that I started was actually with our telehealth program. Originally, when I took the position, the daily monitoring of our patients on telehealth was being outsourced to the company that supplies our equipment. Out of the 50 units that we have, oftentimes you would see at least a dozen of them just sitting in the office collecting dust and not being used. After learning what a valuable tool it was to help keep our patients out of the hospital, I began to ask some questions, like why outsource the alert reviews when it can be done in-house, quicker, and with more consistent patient contact? Are we using the telehealth to the best of our ability? And what else is out there for better telehealth program management and technology? One thing I found was that most of our nurses were only ordering telehealth for patients who had just come out of the hospital for CHF. So I started reviewing records of new patients, trying to assess, their medical history, any cardiac or respiratory comorbidities, along with some other high-risk factors. And for any patient who seemed appropriate, I would reach out to their case managers. I would educate them as to what I could see in the medical record and how telehealth may be beneficial to these patients. With this education, our telehealth use has increased. Now, all 50 of our units are out on a regular basis. We often have a wait list for patients who need telehealth in their home, which requires some in-house triaging. Another thing I learned about telehealth was that the new technology with video monitoring was having a significant effect on rehospitalization rates for home care patients with CHF. I brought the idea to the directors here, and it was well received. The agency has been able to obtain some grant funding to start the upgrade to tablet video monitoring systems, and we will be implementing about 20 of those in the upcoming months. So in addition to the 50 non-video units we have already in place, we will be adding another 20. Daily, I monitor the vital signs and the answers to questions about disease-related symptoms on the telehealth that the patients will answer in their home. I call the patients when the readings are out of range that we have set by agency standards to see how they're doing. If needed, I will reach out to our scheduling department for a nursing visit, contact physicians to obtain new orders, and provide over-the-phone support and education to the patients. These patients remain on telehealth for an average of 3 to 4 weeks, and over that time I develop relationships with them and their caregivers. I educate them about the benefits of obtaining a scale, home blood pressure, cuff, pulse oximeters, and try to get them engaged with them, the patients and their family, to help start monitoring at home as just another way to help them stay out of the hospital long term. I also needed to learn more about high-risk patients and how to identify them. So I researched multiple risk assessment tools. I reviewed the tools that our clinicians were already using and how we were making them work for our agency. The problem was no tool is the same, and they all give varying answers as to who or what is high risk. So I reviewed charts of our hospitalized patients to see what they had in common. But because there was such a variance amongst not only the tools, but also the clinical judgments of our clinicians, I wanted to find a way to kind of take that part out of the equation. So we developed high-risk parameters that were more customized to our patient population, and that was how I started to identify a group of patients under the class of chronic care. And what this did is it gave me a group of patients that I could follow, reach out to by phone calls and home visits, and to provide them with specific symptom assessment, disease education, medication education, and support for the patients and caregivers on how to keep them out of the hospital. And you're going to hear me say that a lot, out of the hospital, but that is the primary focus of what my job is to help these patients learn and stay out of the hospital. And while this list of chronic care patients contains a variety of different diseases, most of them had cardiac disease, and the major one was CHF. So the next challenge was my own true understanding of our biggest rehospitalization disease, heart failure. That was when I discovered and started pursuing the heart failure nurse certification. This certification requires a certain amount of CEUs, which are heart failure related, along with multiple work hours, depending on the type of position that you have. But throughout this education, I've learned so much about how to better help our patients. With the education that I received, I developed heart failure education for our clinicians, including education about front-loading visits, which has shown to help really keep people out of the hospital, using telehealth, disease process, and the different forms of heart failure so they can be more aware of the symptoms that their patients may be presenting with, and how to teach the patients about heart failure. Research has shown that contact with home care patients, be it a visit or a phone call, helps decrease the chances of a patient going into the hospital. So every day, I try to make phone calls to chronic care patients who don't have either a clinician going out to see them or a doctor's appointment. I try to be that contact on their off days, asking them how they're feeling, any changes in their symptoms, educating them on what changes to look for and what to do in the event that they are aware of them. This phone call allows me to facilitate nursing visits if there's been a change. If needed, I will contact the physician on behalf of the patient and keep the care team up to date on any changes or make recommendations to the patient's plan of care. Now, these recommendations can be anything from what the patient needs more education on based on our conversation to having discussed other services with the patient, including therapies that might be beneficial that maybe they have refused in the past. And I recommend that the case managers and the care team follow up with the patients in their home and obtain orders for what is needed. Over the last few months, I've started making visits to patients' home, providing education on specific disease management, The patients that I visit are often the ones with new cardiac diagnoses, documented difficulty with adherence to their disease management, and post-cardiac surgery patients. A chronic care nurse visit is what I consider to be a disease-driven visit. That means the education provided during these visits is often related to just their cardiac disease and how to utilize the tools that have been provided to them for self-assessment. Here we have a couple of examples of the tools that our agency uses. On the left, you'll see the heart failure zones. We educate the patients on the goal of being in the green zone every day, to be aware of what symptom changes could cause them to be in the yellow/orange zone, as you see on your screen, and what to do in that scenario to avoid them going into the red zone, which means they will end up in the hospital. One of the ways that we try to do that is with our weight log. You can see we have date, weight, how the weight has changed, and then included is what zone am I in today. This encourages the patients to be more interactive with their care, making them more accountable to pay attention to not just their weight changes, but the symptoms that they have every day, if there's any changes in those symptoms. And then what did I do about it? You know, again, using this as an education tool. Oh, Mr. Jones, I see you were in the yellow zone on Friday, but you went back to the green zone on Saturday. What did you do differently? How did you help yourself? You know, things that we can do to make them more accountable and interactive with their own care. On this slide is just another couple more examples of the tools that we use. These are just the spices of life are just a couple of education tools for reading sodium labels, sodium on food labels, how to avoid salt in restaurants and cooking at home. There's information about how to season without salt, which is nice for a lot of patients. I get a lot of phone calls from the nurses asking me to mail these out to patients to help them. And again, we use a sodium log similar to a weight log or a vital sign log to, again, encourage the patient to be accountable for what they're taking in. So we want them to write down what they're eating or drinking. We want them to write down how much sodium is in one serving, and then how many servings do they have. You know, they have those cans of soup, and they read the label, and it says 460 milligrams, and that's okay, but that's only one serving, and we want to make sure that they know that there's 2.5 servings in that whole can, and how many total milligrams of salt did they get. We want them also at the end, at the bottom of the form, we have how did my sodium intake compare to yesterday, better, the same, or worse. People in general want to do better. You know, they don't want to see that they're doing worse on a daily basis. This, again, encourages that involvement in their care, and it sets a goal for them. I want to do better. I want to do better, and how can I do that? So with the telehealth and the chronic care patients, like I said, I develop relationships with them and their caregivers over phone calls. I like to learn what do they like to do, what is their goal, and what do they want to get back to doing. I not only educate them, but I try to encourage them to live with their disease, to not be a prisoner of it. We hear so many of them verbalize frustration with, I can't have this, I can't have that, I can't do this. I try to teach them that, yes, there are foods they should avoid, but inevitably everybody will have a cheat day. So I try to teach them to not be afraid to call their doctor when they do eat those foods and if they are having symptoms of heart failure exacerbation. My favorite part is when I call a telehealth patient whose weight is up and they go, I know. They know that their weights are up, and they can tell me why. What did they eat? Did they miss their med? They know what did it. But they still need that encouragement to be independent in reaching out to their doctors, being comfortable and confident in making those phone calls. Something I stress with them is that the doctor would rather get a phone call from them saying, hey, doc, I gained 3 pounds from yesterday. My family was celebrating this. There was this. I overindulged in French fries and pizza. I know my weight is up from what I ate yesterday, and I want to know what I should do to help myself stay out of the hospital. That is a phone call they would rather get than the one 3 days later saying that their patient was in the hospital for an 8-pound weight gain that could have possibly been avoided by an extra dose of diuretic. I sit next to our referral center here at the agency, and they often laugh when they hear me giving speeches to patients about sausages that they've been eating every day for breakfast after their wife leaves, or how their 6-pound weight gain in 2 days was not just from being constipated for 12 hours. There's a running joke about the sausage speech around here. It's quite funny. And ironically enough, some of our referral center has changed their sodium intake after all my speeches. What I really love is when patients and their caregivers call me here in the office because they have a question, and they know I will be here to help them. I give them my direct contact information at the office, and I welcome them to call me if they have any questions, concerns, or if they just need to vent one day. Cardiac diseases, cardiac surgery, they come with a lot of lifestyle changes that can be very overwhelming for a lot of people. And their caregivers are doing the best they can to help them, but sometimes they just get frustrated and they need to vent. There has been proof that these phone calls that we make to patients can make a difference. Every week I run a report of patients who were documented as being admitted to the hospital the week before. What has been observed on this report is that on the weeks that the chronic care phone calls are not able to be made to the extent that they normally are, you can see a rise in the hospitalized chronic care patients. However, on the weeks where these phone calls are not affected and they're made routinely, that percentage goes down. Because this process is obviously still developing and I'm the only one who's currently doing it, I can only reach so many patients in a week. I try to touch 50 to 80 out of a census of 500. Because I cannot reach everyone, I try to give information to the clinical managers about other patients that may have an increased risk of hospitalization through a formatted SBAR email. I've reviewed patients who get admitted to our services for high-risk factors and any maybe missing points in their care plans that could affect them staying home. Using that formatted SBAR email, I update the clinical managers of what I reviewed, allowing them an opportunity to do education with their clinicians so that we can all better serve our patients. Upon taking this position early on, I was given the task of diving into the Cardiac Milestone Program with HHQI. And at first, it really just seemed like a lot of data entry. And because I was new to all of this, I didn't understand its value. So along the way, I've received great support from Cindy Sun. She's really helped me to see and understand the milestones and the categories of assessment and the value that they hold. She also educated me about the nationwide Mending Hearts campaign, which was the driving force behind the cardiac milestones, as an effort to decrease cardiac events through specific assessment and education for patients with cardiac disease. So the first one that I was tasked to review was our tobacco cessation teaching. One thing that I learned was that our clinicians do not document well if a patient is a current smoker versus a previous smoker. We really just kind of document history of smoking. I have suggested to the directors that we may need a better way to capture this. It's still a work in progress, but we're trying. However, though, through the research of our records and the hard work of our clinicians, our agency was able to achieve the Cardiac Milestone 5 for the tobacco cessation teaching, being documented and followed through on these visits. So as the only agency in the state to have achieved this, we are very, very proud. But I didn't want to stop there. I wanted to learn more about how we did with the other categories, so I moved on to aspirin. At first, I didn't understand that it had to be antiplatelet-specific treatment, and I was just entering data for any anticoagulation therapy. And of course, our reported numbers were off. So that pushed me to want to learn more about why antiplatelet-specific treatment was being used for ischemic cardiac disease. And through my research and through the information from HHQI, it started to become second nature to assess for those qualifying diagnoses and to see if these patients were on antiplatelet treatment. When I found patients who weren't, I started reaching out to physicians' offices. I explained that as part of the HopeHealth compliance with the Million Hearts campaign, I was following up to see if these patients should or should not be on an antiplatelet medication and trying to get confirmation from their physician so I could update their record. In one instance, I spoke to a nurse at a cardiologist office who stated they actually had no listing of the patient having any history of ischemic cardiac disease and therefore would not be a candidate for medications such as aspirin or Plavix. So this allowed me the opportunity to update the patient's medical record. A nurse in a primary care physician office that I spoke to was not so accommodating to my request. I had explained to her that this was from the recommendations of the Million Heart campaign, not from me and not from HopeHealth. She had made a valid point when she asked me if there was any recommendations from the campaign if patients can't afford a medication such as Plavix. So I politely updated her that it also included aspirin, not just Plavix, and that is obviously a more accessible, inexpensive over-the-counter medication. Turns out one of the two patients I talked to her about ended up with an order from the doctor to start a low-dose daily aspirin regimen. Reminding others that this is not about HopeHealth, it's not about me, and it's not about the doctor's office, but it's about the patients in a national campaign to provide them the best care possible, helps bring down the egos, and allow for better collaboration. The next thing I focused on was the cardiac rehab. And it was very clear from the beginning that cardiac rehab was not something that we really looked to as a part of our discharge planning for cardiac patients, particularly the status post-cardiac surgery patients who really could benefit from it the most. I did a home visit with a patient who had had a CABG ×4 in an urgent and stressful situation. He was exhibiting some post-surgical depression. I reached out to cardiac rehabs in my area, but while they provided group therapy and support, he couldn't engage in it unless he was part of their rehab program, which he couldn't do because he was homebound, hence why he was getting home care. So that was when I started looking for some other support for him, and I found there wasn't much out there that I knew about. So after many phone calls, tracking one lead after another, I was able to get in contact with a woman who oversaw a local chapter of a national support group for cardiac patients called Mending Hearts. I discussed with her my concerns about patients needing support in their home while they are homebound, and so began our talk of a collaboration. We discussed options on how to get the information between the patients and Mending Hearts and how to do so without a HIPAA violation or having to have patients sign multiple more forms. With the members of Mending Hearts getting older and the upcoming age group of patients with cardiac disease and surgery using more of a technology means of interaction, it seemed the best way to start was with a phone call from our patients directly to the president of the local Mending Hearts chapter. This would allow the patients to reach out on their own, talk about what they have been through and what they are feeling. Then the chapter president can set them up with a member who has been through a similar situation who can help our patient process what they're going through. From there, the chapter president will provide that Mending Hearts member with the contact information that the patient provided to her, and a reach out will begin. Not only will this collaboration help support our patients in a new and hopefully long-term way, but it can also help our patients get a better view and understanding of cardiac rehab from someone who's gone through it, with a hopeful result of increased cardiac rehab use of patients who are eligible for and can benefit from it when they are no longer homebound. We are still working on the details of this initiating this collaboration, but I'm very excited about it. Goals moving forward for me this year in my role are to obviously, one, decrease rehospitalization of heart failure patients on telehealth by utilizing our new platform tablets. I also would like to increase our cardiac rehab referrals to 25% of all eligible patients, and to continue overall progress in improving our cardiac program through patient and staff education. A couple of points that I would love for everyone to be able to take away today is if you have a telehealth program, review it, make sure that you're utilizing it to the best of your ability. There's so much that can be done with it, not just with cardiac patients, but other patients who have multiple risk factors that really can make a difference. Understanding your patient's needs. Cardiac patients need a lot of education. We all know CHF patients need to know low-sodium diet. They need to know the zones. They need to know the weight log. But every patient is different in the specifics that they need to know. New diagnosed heart failure patients tend to need to know more about the disease process and what is going on. Some patients need more understanding and education about the low-sodium diet and how that really does affect their heart. Some patients need more specific education about the medication and understanding the importance of their diuretic. So understanding what your patient's needs and weaknesses are helps you develop a better program for them. Disease-driven visits, really focusing in on that specific disease process, helping the patients understand, can make a difference. I've sat with patients and drawn pictures and diagrams and, done an acrobatic play if need be to help them better understand what's going on. And don't be afraid to reach out for more support. Had I given up on trying to find support for that patient, I never would have found Mending Hearts, and there's so much benefit to the more support we can provide to our patients. Teamwork is key. A chronic care program really only works with teamwork. It has to be a team collaboration, and it has to be a care team taking care of these patients. It's not a one-man show, and every team needs practice. Chronic care is not a one and done. This is a constant evolving and changing practice because these diseases are constantly changing and evolving, and how we treat them evolves. So I would like to thank you all very much for your time today and listening to my story, and I'm going to turn it back over to Cindy for any questions.
Well, thank you, Angela, and I think I will speak for everybody in saying this was a fantastic way to share what's going on at your agency. I want to remind everybody that send any questions that you do have into the Q&A box, or if you are listening only and not participating in the webinar, you can reach us live at HHQI@qualityinsights.org. And we do have a couple questions coming in. The first one is a general question, which I think everyone will be interested in. Is this being recorded, and will it be available to participants? Yes, it is being recorded, and it will be available to participants. It'll be under the Cardiovascular CardioLAN webinar link on the HHQI website. If you can't find it, and it's usually up by the beginning of next week, if you can't locate it, you can contact us and we will get the link to you. The next question we have is about the telehealth, and it's a couple questions combined here. So for those of you asking, forgive me if I miss your question. I'm going to combine these two. What is your criteria for deciding who gets telehealth, who gets waitlisted, and who jumps to the front of the line, and what factors determine when to remove telehealth?
Okay. So telehealth can really be used for any patient that a nurse feels is at an increased risk of going back to the hospital. Some of the criteria you want to look for, obviously, are patients who have significant comorbidities. Do they have CHF, COPD, diabetes, chronic kidney disease, hypertension, the big ones? Do they live alone? Telehealth can be a great tool for those patients who live alone, especially if they have anxiety or depression, as it can be an outsource for them. It's a contact for them. It gives them that comfort of knowing someone's on the other end looking at what's going on with them. As far as the wait list goes, we try to get the units out as soon as possible when patients come on. Obviously, if we have multiple patients waiting, we really have to look at the risk factor. Is this somebody who's already gone into the hospital a couple of times for a CHF exacerbation? Is this somebody who has multiple comorbidities and lives alone versus someone who just had a carotid enderectomy and has multiple family members living in the home supporting them? So there's a lot of factors that go into it, but you really want to look for the patients who can benefit from it the most, the ones who have the highest risk factor of going back into the hospital. You know, again, do they live alone? Do they have multiple issues with diseases? Do they have multiple medications? Is this someone who's going to need that extra set of support?
And what factors determine when to remove somebody from telehealth in your agency?
Thank you. So we try to leave the patients on for about 3 to 4 weeks. We really want them, encourage them to get used to doing it every day and to obtaining their own equipment, scale, blood pressure cuff, and pulse ox. And then we try to educate them about how to monitor themselves at home and discuss the plan to remove it. The goal is to remove the telehealth at least a few weeks before they're discharged from our agency, because we want to give them an opportunity to be independent with their care without having that crutch to lean on, but still having the support of the agency there in case they have any questions.
Well, that makes a lot of sense. And I'm sorry, I combined all those questions.
That's okay.
Next question we have. What instigated your agency to develop the position of chronic care nurse navigator?
Okay, so we have obviously a vast census of patients going anywhere from simple knee surgeries to our more chronic ill end-stage patients that we consider to be palliative care. But in researching our hospitalized patients, there was a noticeable difference in that there was a smaller group of patients who had the chronic diseases, who were being hospitalized multiple times for the same issues, but were not quite palliative hospice appropriate. These were patients who needed a little bit more oversight, a little bit more education and support, and that was the development from there, that we needed someone who could do that.
And this is a follow-up question to that one. I think it's from the same person. What was the typical reaction by other staff to this new role?
Well, being that this was something that was completely new, just developed, there was obviously a lack of understanding at first from clinicians out in the field of how, in my role, I could help support them and their patients. So there was a lot of education, a lot of emails going back and forth, trying to let the staff know kind of why I'm here, what am I here to help them with. And as my role progressed and I became more involved with the patient care, doing visits, helping reaching out to physicians to obtain orders, the staff definitely became more receptive to the role and now are reaching out to me for some guidance on these higher risk patients. You know, there's been a change. What can we do differently in their plan of care to help this patient stay home? So, again, in the beginning, there was a gap of understanding, but now that the role has developed more, there's a lot more collaboration between myself and the case managers and the clinicians to develop the best plan for these patients.
That sounds like a perfect team approach. I'd be interested in hearing from the rest of you through either the chat or Q&A feature if this is something that you all have instigated at your agencies as well, or if you're thinking about it. Just share with each other and share with us. We're interested in knowing of how it's going out there. We do hear of agencies that are instituting this particular position. It may not be the same name, but the same concept and the skill set of moving forward. And while we wait for additional questions to come in, I wanted to go ahead and review a few resources. But as we're doing this, please feel free to go ahead and submit your questions to Angela and take advantage of her time that we have her here. All right, just a few additional resources. As I was looking through Angela's slides, I wanted to provide resources that are available on the HHQI site to support the content of today's session. So as many of you are aware, the Disease Management Heart Failure BPIP is out there. It has been updated, as well as the cardiovascular BPIPs that are updated. They're available. And as you can see, it is the overview of the heart failure, medication references for your clinicians, not just for your patients. Of course, there are many self-care resources available because that is what we're all about, and it's what Angela has spoken to so nicely today about improving self-care management amongst our patient population. Additional clinician resources, this particular clinical evidence-based practices, takes through an additional step of looking at the medications, the physician appointments, the specifics about the symptoms and the weights and the fluids. How much weight, what milligrams of sodium, what are we talking about, what are the specifics? How do we address the questions of alcohol and caffeine limitations with our patients in the home? And of course, tobacco cessation. And just a side note for those of you that are focusing on smoking cessation and tobacco cessation in your agencies, I'm sure you're remembering this, but I just feel it would be lapse if I didn't mention it. Remember, 1036 is gone. For those of you that are focusing on this, if you have not integrated an additional question into your start of care assessment, tobacco assessment is probably not going to be accomplished. So keep that in mind as you are moving forward. Zone management tools, there are multiple out there. This particular one is on heart failure. There are, of course, the My Emergency Care Plan as well. Now, the fact of what Angela's agency is doing, and yours may be doing this as well, but adding the zone tool column, what zone are you in, on the daily weight logs for your patients with heart failure is, I think, a fantastic way to encourage that patient self-management so that they can see the cause and effect. At least have them identifying what are the green, yellow, and red zones so that they can know these before they start moving around. And we've told you this before, and I share this, and I'm sure you all are tired of me saying it. But this was not my idea. I just thought it was a great one. But remember, when you are working with caregivers that are distant, those family members are going to be calling the patients usually pretty frequently, more frequently than we are sometimes. And in those cases, sending them a copy of the zone tool or the weight log, let them know what the patient actually has in the home, will help keep that moving along so that we're all collaborating with our families and caregivers in helping this patient stay in the community. Heart failure management, definitely a great one. It's a specific action plan for heart failure patients. There's another action plan in a minute I'll share with you. Diet and exercise, these are great handouts. Again, these are also really good to share with family members, even if they're distant and you have to put it in an envelope and send it to them. Now, additional clinician and patient resources with the Heart Failure Telehealth Toolkit. All of the telehealth toolkits on HHQI are currently, right this minute, being revamped. And these are being posted sometime between yesterday and the next month because they're coming out in one at a time. So keep an eye out for those. These telehealth toolkits will continue to have the clinician education tools, decision support tools, the patient selection criteria, as Angela was talking about, also the patient self-care workbooks, and the patient encounter documentation tools so that can be used to enhance your telehealth program. This is not to replace anything you already have. It's just to enhance what you're already doing. Keep this in mind as you are working forward. If you're not familiar or if you've had the same tools in place for 10 to 15 years, you may want to pull them out and at least just glance at them and make sure that they still have the current evidence there. Patient education workbooks. You know that these are fantastic if you are able to use them properly. Instead of just giving them to the patient, we want to make sure our clinicians are able to use these as talking points. Just focus on one particular paragraph in the workbook, and it doesn't have to go page by page. Let the patient decide what they're going to do, but then having these workbooks as a tool for the clinicians really is helpful. It also helps with continuity between visits as well as between providers. So as the patient is going into the physician's office, they can take their workbook with them so the physician's office can use the same teaching tools that you're using in the home. Cardiac Rehab Fax Sheet. This is made for the patients, and it does describe exactly what it is. And if your if your clinicians are not familiar with rehab, and many home health clinicians are not, this is a gap that has been noted between home health and rehab, and it's something that we can ourselves can take care of this. If your clinicians are not familiar with it, they may find this beneficial as well. But in a minute, I'm going to show you a cardiac rehab sheet for clinicians as well. As I mentioned, there are many action plans that are available on the HHQI website. The earlier one was for heart failure specific. This one is a general action plan that is useful in helping the patients decide what's important so that we can all work together to get towards the same goals. Call Me First posters. If you do not already have them, make sure that you are doing some form of communication with your patients and families to allow you at the agency to have the opportunity to work with this patient before they go to the emergency room and before they go into the hospital. It doesn't have to be this poster. It's whatever you're using, but just make sure that the patients are aware that we are here as home health to help you unless it is a 911 emergency. Medication management. I promised myself I wasn't going to say it, but I'm going to. This is my all-time favorite tool. Okay, the first one is a schedule. That is available if your patients have multiple meds throughout the day, and this will help with their adhering to their medication list. But this, My Medication Pocket Card, that's it. That's my favorite. It is a Word document. You can download it, and it's my favorite because I use it for most of my family members. This can be used and sent to your families as well so that if they're helping their patient, once you are out of the home, this will continue. This will sustain the level of quality of care that they're receiving. It can be typed and edited very simply, or you can give it to the patients and they can simply fold it up and put it in their wallet and take it from physician to physician. Fax Communication Sheet, as Angela was talking about, I think we've all encountered, if we're not, our approach, it's not really our approach, but the receiving of our calls when we're asking for, should this patient be on aspirin, should this patient's blood pressure be a little lower, we need to, sometimes we're not getting the responses that we want, just exactly what Angela described. In an effort to help with that, this is a fax sheet that's available. You can upload it into your system if you are doing e-orders, or you can actually use it as a fax cover sheet. It can be signed. You can edit it. It is a Word document. Remember that everything on HHQI, unless it says that it must be used in the actual format, you can edit this as you see best for your agency. So I wanted to make sure we shared that. This is the cardiac rehab fact sheet for your clinicians. As you can see, it is not intended for patients. It's not health literate. But if you have an advanced level learner in the home, of course you can share this with them. This is from the Mending Hearts initiative, and it does give the overall information of the importance of cardiac rehab for all patients, not just home health. University courses, I always like to share these because it seems like every week I talk with agencies who are recreating the wheel. We don't want you to waste your time on that. If there's something here that is useful to you, we want to just at least bring it to your attention so that you can spend your resources on other areas. The university courses, as you know, they're available to everybody. The reason these are in parentheses saying nursing and PT, those are just the CEs that have been approved. But everyone can access all of these courses. So as you are developing your QI plans, if you find a course that would be useful, all you have to do is assign it. Your clinicians can come in. They'll do their independent registration, and all you'll need is to ask them to turn in their certificate of attendance. No matter the discipline, everyone gets a certificate of attendance. So hopefully some of these will be helpful and save you time. That's what we're looking to do. I put these two on a specific slide simply because these are focusing on heart failure, and as you can read, exercise prescription for heart failure patients, and then also maintenance therapy for patients with heart failure. These were presented by Dee Cornetti and Cindy Kraft. These are the two longest webinars that we had in the CardioLand if you were participating a year ago. They were 2 hours each. They were very well attended. I also mentioned that in case you have clinicians and therapists who were already attended these, but know that these are available. CEs are awarded. I also wanted to link Mending Hearts. As Angela found, this is a group that is a nonprofit organization that is available in many areas of the country. The link is here on the website, on the slide, and you can go to their website and they have an interactive map. Find out if they're available in your area, if you feel that this would help meet a need of your patients. Last thing I wanted to mention are the upcoming events, simply because these really pertain to our CardioLand world. Even though it's the underserved population in April, it's engaging caregivers, not only to engage in the care of the patient, but how can our caregivers help us as agencies participate and improve our own quality that we're delivering. The guest expert will be presenting this information as well as discussing the two different acts that are before at a national level, CARE and RAISE. And our next CardioLand will be on June 20th at 2 p.m. Eastern. I wanted to just put that out there as a save the date. Now, let's get back to the questions. We've had a few more come in, and Angela, if it's okay with you, I'll continue to ask those if you don't mind.
No, go ahead.
Were there any other challenges beyond what you described found when changing the focus to preventative cardiovascular care? And if so, how did you address these?
So changing from reactive to proactive care, it really is a mindset. It's a change in mindset of how we do things. As clinicians in general, when we see a problem, then we want to fix it. It's about acknowledging that there's a problem before it happens. And obviously changing a mindset, and any nurse who's on the line will agree with me, is very hard. Nurses get very stuck in their ways. So really trying to reach out to clinicians and managers and help them see, like, this is what I'm seeing. This is what in this patient's record is red flagging as a possible problem that can affect them to go into the hospital. That is an ongoing thing. That is a constant challenge that we all face, I think, in trying to look at the chart differently. So we've done the emails, we've done meetings, really just trying to help. But again, changing a mindset doesn't happen overnight, so that is a continuing process.
Thank you. And the next question is, would you mind sharing what your caseload is? How many patients do you see in a day or a week?
So the patients that I see vary. The list of chronic care patients that I review is around 80 patients. And what I do with that list of patients is I really look at them weekly. I look at their plans of care, I look at their visits, I make phone calls. I try to call every one of them at least once a week. Sometimes I have to make multiple phone calls. And as far as the visits go, sometimes I'll see no patients, and some weeks I see 6 patients. And the reason that is because I try to pull the patients who need that extended visit, that extra time to really educate.
And if someone is starting this position, what would you consider to be an appropriate caseload? And I know that's a general question, but just in general, what would be an appropriate way to start?
So when I started, I tried to keep it around 25. That allowed me an opportunity to follow these high-risk patients, but also continue to do my research into how to best help them. Obviously, as I've done the research and learned more of what to look for, how to help them, how to drive the education with them, I've been able to add more patients on. So I would say to start 25 is a good place.
And other than the type of education provided, what's the difference between disease-driven visit and a normal skilled nurse visit?
So, in home care, your nurses go out and they're seeing multiple patients in a day, and they have multiple things that they have to cover. And our clinicians do a great job of teaching the patients, the weight log, what to look for. The disease-driven visit for me is much more specific. When I go in with my bag of tricks, and I'm working on specifically heart failure, specifically hypertension, regardless of how many other comorbidities they have, I'm focused on that one. For example, I had a patient who gained weight on his telehealth, and I went out to see him because he told me that he had eaten ham and that he threw the ham away, and if the weight went up again tomorrow, then it wasn't from the ham. So I had to go out, and we did some education specifically on how that ham with the sodium affects his heart failure and the fluid retention. And I spent over an hour just having that conversation. And it made a difference because the next day his weight went up, and by the time I called him, he had already called his physician to let them know. Another example is, with knowing your patients too with these visits. I walked into a patient's home prepped and ready to talk about heart failure. And the moment I said it, she told me she did not have heart failure. So I went to open my laptop, and the battery was dead. So imagine I'm out on sea with no oars, and I don't know what I'm going to do. But I knew she was on Lasix, and I asked her why she was checking her weight every day, and she told me she didn't know. It was just because that's what they told her. So I started educating her about the Lasix, and she told me that her doctor had put her on that many years ago for a blood pressure control. So while I had intended to talk about heart failure, I knew I could work it into high blood pressure. So I educated her that the furosemide helps her blood pressure by keeping the extra fluid off, and that's why you check your weight every day to make sure that that medication is working to control her blood pressure. So now all of a sudden she's engaged. She went and stepped on her scale. She showed me how she did it. We talked about it. And she mentioned she wanted to lose weight, which was a perfect opportunity for me to go into a low-sodium diet. And I explained to her that a low-sodium diet can help control her blood pressure and help her lose weight. And now she was going through her cupboards and ripping out everything she had, asking me to read the labels and, what was good, what was bad. So, I had this intent to be focused on heart failure, and instead we changed it to hypertension. And that was what the whole visit was about, was her managing her hypertension with the same interventions really that we would use for heart failure. I ended up getting a phone call from her physician later on that day who did confirm she did have mild heart failure. And I explained to him what I did, and he goes, okay, continue with the hypertension education then, and I'll discuss the heart failure with her when she comes back in 6 months. So, the disease-driven visits, the chronic care visits, you really get to stop and work with the patients and focus on that specific item versus I have 7 patients that I need to see in one day, and today's focus can only be this.
That is a very nice summary. I think we can all, I'm sure everybody, we were all on mute, but we all had a few giggles for those of us that have been in the homes before. Oh, yeah, we've had that. We've all faced that. It sounds like you've done a wonderful job. With this, I think we're going to go ahead and close. I want to reiterate what I'm seeing coming through the chat and the Q&As of great presentation, and thank you very much. We all want to thank you, Angela, and HopeHealth Visiting Nurse, for sharing your experience, your expertise, and really just helping all of us continue to think outside of the box. For those of you that are listening to the archive recording, or for those of you that are participating live, if you have additional questions or if you'd like to reach Angela in any way with additional questions, please feel free to contact us and we'll get you in touch. We're at HHQI@qualityinsights.org. And with that, we will say thank you, everyone, and have a great day.